Good afternoon, everyone. I am Ángel Sánchez Recalde from Ramón y Cajal Hospital in Madrid. And this is the second webinar about imaging and coronary physiology. And this webinar, as another webinar, has two parts. We have a presentation, in this case about INOCA, and we have a live case that we will present in a few minutes. So we will start with the presentation, and it's a pleasure and a great honor to have Adelaide Chieffo from Italy. She is the clinical research director in interventional cardiology at San Raffaele Hospital in Italy, and she is one of the biggest experts worldwide about coronary physiology, imaging, and interventions. And also, she is a co-chair of the expert document of the European Association of PCI. So, Dr. Chieffo will present a talk about INOCA, and then we will present a live case. In our lab with me is Dr. Javier Escánez, and it's an honor to have Javier with us today. Javier is the father of a lot of things. He's the father of non-hyperemic pressure indices, and I think he's one of the first doctors to highlight the importance and the relevance of assessing the microcirculatory status of the patients with angina. So without further ado, Dr. Chieffo, can you present? Thank you.
Sure. So first of all, good afternoon to everybody. It's a pleasure to be here in Spain in this beautiful Cathlab in Madrid. As I said, I did my Erasmus when I was a medical student in Madrid. So it's a place that really I have very good remembering, great time there. So it's a pleasure for me to share with you the EAPCI consensus document on INOCA. As it was said, I had the honor to be co-chair of this document. And with us, there was also Javier that is with you in Cathlab. So what is, first of all, what are we talking about? INOCA is ischemia in non-obstructive coronary artery disease. Just a reminder, there are different causes of myocardial ischemia, and coronary stenosis and the presence of a significant coronary stenosis is only one of the causes of myocardial ischemia. But we should move from the coronary stenotic effect to all the other causes of myocardial ischemia. One of the causes of myocardial ischemia is coronary microvascular dysfunction, but also vascular spasm, or the presence of a myocardial bridge, or also primary metabolic abnormalities, inflammation, systemic inflammation, and autoimmune disease, and platelet and coagulation. Again, this to give you the idea that a coronary stenosis as causes of myocardial ischemia is only one of the possible causes, but there are several others. As I said, I had the fortune to be the co-chair of this document. The first idea to have an expert consensus document on the topic came from the women committee from EAPCI, and then it was decided by the board of EAPCI to have a document not only from EAPCI, but together with the working group on coronary pathophysiology and microcirculation, and the document was endorsed by Coronary Vasomotor Disorder International Study Group. Just to give you the idea that this was really a common effort and big working, the work of a big team of experts. The paper was published in European Heart Journal last year and simultaneously to Eurointervention. Just to give you an idea on how this topic got again popularity, because it's something that is ongoing since a bit of years. is the fact that the document was the most cited and referred document article that was published in our intervention last year. So it was rated as the most discussed paper from our intervention in 2020, just to give you an idea how much popular is getting the concept of INOCA. So again, what are we talking about? We are talking about ischemia and non-obstructive coronary arteries that can be a coronary microvascular dysfunction, which means impaired coronary physiology and myocardial blood flow in subject with risk factors, because these are patients that have also what are known cardiovascular risk factors like smoking, hypertension, diabetes, or overweight. And this causes microvascular angina. It contribute to myocardial ischemia in coronary artery disease. And then you have vasospastic angina, which can be a transient vasospasm that led to Prinzmetal angina, but also a persistent vasospasm leading to myocardial infarction. Non-obstructive coronary atherosclerosis is frequently present, and this mechanism, so the presence of a coronary macrovascular dysfunction and a vasospastic angina, can overlap. And then you have indeed ischemia with obstructive coronary artery disease that is due to the presence of atherosclerotic disease in epicardial coronary artery with a stable plaque and reduction in FFR with demand ischemia and angina, or vulnerable plaque that led to plaque rupture, thrombosis, and acute coronary syndromes. So when you do a diagnosis of microvascular angina, you can do a diagnosis of microvascular angina is only if criteria 1, 2, 3, and 4 are present. Criteria 1 is the presence of symptoms of myocardial ischemia as effort or rest angina or exertional dyspnea, so shortness of breath. Criteria 2 is the absence of obstructive coronary artery disease, less than 50% diameter reduction or an FFR more than 0.80. And you can diagnose these not only at invasive coronary angiography, but also at coronary CT scan. Criteria 3 is the presence of objective evidence of myocardial ischemia with presence of reversible defect, abnormality, or flow reserve on a functional imaging testing, and impaired coronary flow reserve with a cutoff less than 2.0 invasively, or this can be determined also non-invasively. There are also non-invasive diagnostics that can give you information regarding coronary flow reserve, such as, for example, PET. And then evidence of impaired coronary microvascular function, as we said, apart from impaired coronary flow reserve, also coronary microvascular spasm, defined as reproduction of symptoms, ischemic ECG shift, but no epicardial spasm during acetylcholine testing, or the presence of abnormal coronary microvascular resistant indices with an IMR more or equal to 25. And again, you can define the presence of microvascular angina if criteria 1, 2, 3, and 4 are present. As we said, it is possible to have a diagnosis then of microvascular dysfunction not only with invasive testing, but also with non-invasive evaluation. And the document also discusses about that. The first step you have to take into account when you are suspecting to have an INOCA is patient evaluation. So collect the history of the patient, including risk factor, physical examination, convincing ongoing history of cardiac ischemia with EKG non-diagnostic or normal, and cardiology referral. Step 2 can be non-invasive evaluation, preferentially considered if there is a high clinical likelihood or revascularization likely or local expertise in availability and viability assessment required, you can go indeed to invasive evaluation. Functional imaging with exercise tolerant test, echo, myocardial contrast echocardiography, myocardial perfusion imaging, PET and CMR, and you can also consider the presence of coronary CT scan. Then next step, after a non-invasive evaluation that can have a step 1, as we said, of patient evaluation, step 2, non-invasive evaluation with functional imaging plus or minus coronary CT scan, there is the invasive evaluation. With the step 1, with invasive coronary angiography performed, step 2 is indeed evaluation of physiology using specific guide wires and adenosine tests, and step 3, the vasoreactivity with acetylcholine testing. And according to that, you will have diagnosis of INOCA endotype with epicardial vasospastic angina, microvascular angina, or the mixed form of microvascular and epicardial vasospastic angina. And according to the INOCA endotype, the different management of INOCA with the correction of lifestyle factor, risk factor management, and prescription of anti-anginal medication. So when you consider invasive evaluation, as we said, these are patients that are undergoing to coronary angiography. The first evaluation is regarding the extent of coronary stenosis. You can have completely normal coronary epicardial coronary trees, or you can have a mild, less than 50% coronary stenosis, or a moderate 50 to 80%. Then step 2 is clearly if you have more, this is an ischemia due to the presence of significant coronary stenosis and the patient is revascularized. Indeed, if you don't have a critical stenosis by angio, next step, according also to the guidelines, is the evaluation of the patient through the evaluation first of an FFR. And when you have an FFR which is less than 0.8, again, this is an indication for revascularization. Indeed, if the FFR is more than 0.8, you can move to the further physiological evaluation with the CFR and IMR. In case then FFR is normal, more or equal to 0.8, and CFR is more or equal to 2.0 and IMR is less than 25, you don't have coronary microvascular dysfunction present, and in this case you go to the step 3, which is vasoreactivity testing with acetylcholine testing. Indeed, if you do have normal FFR but a CFR less than 2 and an IMR more or equal to 25, this is diagnosis made of coronary microvascular dysfunction. However, also if you do have a diagnosis of coronary microvascular dysfunction, since we said that you can have a mixed form of microvascular dysfunction plus also vasospastic angina, you move also in this case to step 3, which is the testing of vasoreactivity and specifically acetylcholine testing. According then to reaction to acetylcholine, you can have 4 different possibilities. The first is that you don't have reduction of diameter, you don't have angina, you don't have ischemic Ekg changes, and so in a patient who has a negative response to vasoreactivity testing and also had a negative response to coronary physiology, so had no abnormality of coronary physiology, both tests are negative. So in this case, you can conclude that the patient has a non-cardiac pain. So this is the end of the story regarding cardiac disease. Indeed, if the patient has a negative coronary coronary physiology testing, so the indices are normal, and you have indeed at vasoreactivity testing more or equal to 90% diameter reduction, angina, and ischemic Ekg changes, this is an epicardial vasospastic angina. And then if you have a patient who have at coronary physiology indices like CFR less than 2.0 and IMR more than equal to 25, so you do have a coronary microvascular dysfunction, but indeed the acetylcholine test is negative. In this case, this is a pure microvascular angina. And the fourth possibility, INOCA endotype, is indeed that you have both possibilities. So you do have coronary microvascular dysfunction plus positivity to acetylcholine testing with no or less than 90% reduction or more than 90% reduction angina in ischemic Ekg changes. And in this case, this is a mixed form, so it's a microvascular and epicardial vasospastic angina. As you say, according to this different step invasive evaluation, you can, at the end of the process, first doing FFR, then doing the measurement of CFR and IMR, and finally with a step 3 of vasoreactivity, you can end up with 4 INOCA endotypes, going from non-cardiac pain to epicardial vasospastic angina or microvascular angina, and then the mixed form of microvascular and epicardial vasospastic angina. And as we said, you can come out with diagnosis of the 4 INOCA endotype, as we said, microvascular angina or CMD. Again, just a reminder, you have FFR more than 0.80, CFR less than 2.0, IMR more than 25, and indeed the vasoreactivity test can be negative. Or you can have a vasospastic angina with epicardial spasm, again FFR more than 0.8, CFR and IMR are non-pathological. Indeed, you have a positive vasoreactivity testing with diameter reduction more than 90, angina and ischemic Ekg changes. Or you can have the mixed form with both microvascular and vasospastic angina. So you do have both CMD and epicardial spasm. So both the index are pathological with the CFR less than 2.5 and IMR more than 25, and you do have also a positivity to vasoreactivity and acetylcholine testing with the presence of angina, ischemic Ekg changes, and reduction of the stenosis. And then you can have non-cardiac chest pain where both testing are negative, or you can have a non-flow limiting coronary artery disease when indeed you do have a diffuse coronary artery atherosclerosis. So the whole point is why it's so important to have diagnosis of INOCA endotype, because clearly to all the patients, what is common is correction of lifestyle factors through reduction of overweight, exercise, smoking cessation, and coping with the stress. Then this is then correction of lifestyle factors. Second, you do have management of risk factors because you have to take care about hypertension, dyslipidemia, and diabetes that most of these patients have. And then because according to the INOCA endotype, you can tailor your anti-anginal medication. Why that? Because clearly in all patients, it is recommended to have statin and ACE inhibitors or RMB. But if you do have a diagnosis of microvascular angina, you most frequently can prescribe beta blocker, or in case this is not working, calcium channel blocker, and other possibility can be nicorandil, ranolazine, ivabradine, and trimetazidine. Indeed, if you do have diagnosis of vasospastic angina, first line therapy is going to be calcium channel blocker, and then you can prescribe long-acting nitrates and nicorandil. So the INOCA endotype diagnosis is going to drive the therapy that these patients are going to have. Why that? Because these are patients that most frequently are denied, and unfortunately they have a severe limitation in their everyday life. They can have even limitation in their working life, and it's difficult. It has been difficult in the last years to have a clear diagnosis of the patient, but as in this consensus document was very widely described, there is the possibility through non-invasive and also invasive testing with the new system that became available to have a diagnosis in the Cathlab, and according to the diagnosis, tailor your therapy to this patient. Key messages from this expert consensus document were that a large proportion of patients undergoing coronary angiography because of angina and evidence of myocardial ischemia do not have obstructive coronary arteries, but have demonstrable ischemia. And this entity is defined as INOCA. And you can have CMD alone or in combination with CAT, is a mechanism of myocardial ischemia and symptoms in INOCA, or you can have epicardial vasospasm alone or in combination with CMD, that again can be a mechanism of myocardial ischemia. Non-invasive functional techniques are options to detect ischemia in INOCA, and you can do, as we said, TTDE, MCE, SPECT, MRI, and PET. But however, you can do a complete diagnosis in the Cathlab during coronary angiography that is prescribed in patients with ischemia and, by the way, positive stress test. And you can use coronary angiography, and interventional diagnostic procedure should be implemented to differentiate between vasospastic angina, microvascular angina, and non-cardiac pain, through diagnostic guide wire pressure and flow measurement and pharmacological coronary reactivity testing, as we discussed. And these lead to a stratified approach to management of INOCA to address the short and long-term well-being and prognosis, which is warranted. So tailored counseling on lifestyle factor, risk factor management as per CVD prevention guidelines, and use of pharmacotherapy to alleviate ischemia and symptoms. And given the lack of in-depth knowledge, however, the working group suggested to perform further research urgently needed to increase our mechanistic understanding and to develop innovative therapies to better manage this serious condition. Also because you have to take into account that there are patients that do not tolerate fine, for example, in case of vasospastic angina, high dosage of calcium antagonists, which are warranted in this kind of diagnosis. So thanks for your attention. In this slide, you see all my contact from the mail to the Twitter and Instagram account, and clearly I'm more than happy to answer to all your questions. So you can use the question and answer possibility of the platform, or also later on if you want further clarification.
Thank you so much for your presentation. Then we have some questions, and people can send your questions online, and we will answer them in the end of the session. Then we will start with our case. I only have only one question. In your Cathlab, what's your protocol? Which patients, when you perform the test, the same procedure in another procedure, and which technique do you use?
So the big limitation for me is the fact that I did not discuss during the talk, but that patients should be in washout from drugs. So they should be in washout from beta blockers, calcium antagonists, nitrates, or any kind of vasodilator. So if they are in washout from this drug, in the same procedure, I can, if I do see a patient with chest pain and positive stress tests, again, in washout from this kind of therapy, and I do see that there is non-obstructive coronary artery disease, I proceed with the protocol described in the consensus document. Indeed, if the patient is on therapy, I first do the coronary angiography and see the FFR. If they are negative, I have to have the patient, after he's in washout from drugs, again coming back to do the testing of physiology and then acetylcholine. So this all depends if the patient is on medication or not, because what is important is that you have to do in washout.
Okay, thank you, Naraide. Then we are going to present this case, the live case, and Dr. Maria Abellas will tell you the clinical history of the patient.
So, good afternoon. This is a 43-year-old male case. He had previous history of hypertension and smoking habit. Patient was admitted in September 2019 because of an STEMI. Laboratory assessment showed elevation of cardiac biomarkers, and a coronary angiography was performed showing a non-obstructive coronary artery disease. At that point, we interrogated the patient again, and he referred that he had been having some chest discomfort related to the smoking habit. A cardiac magnetic resonance was performed, showing a small area of subendocardial enhancement in septum, and according to all of this, a patient was diagnosed of vasospastic angina, and treatment with calcium channel blocker was started. He remained asymptomatic for a few months, and for the last few weeks, he has started to have again some chest episodes, chest pain episodes, with a good response to vasodilators. So he has been referred to the Cathlab to check if there is another causes of chest pain, or to finally check the diagnosis of vasospastic angina. And this is the coronary angiography with no obstructive disease again in LAD, circumflex LAD, and also nor in the right coronary artery.
Okay, now we are in the live case. We are in the Cathlab with Dr. Ana Pardo, Dr. Javier Scanet, and with our nurses, with Melody, with Maria Jose, with Nuria. And Ana, we will show you Javier will show you the case.
Thank you very much, Angel. It's a great pleasure to be in Hospital Ramón y Cajal with all the team. You've seen the characteristics of the case. Anna explained to me before all the problem. And of course, I think that we agreed, Anna, that this patient, the first thing we may think is that perhaps there is a vasomotor disorder.
Yes.
So, and for that reason, what we have considered is to perform the first part of the test aiming to that direction, because we want to get that information as soon as possible. And we can tell you that the patient had some nitro when we put the guiding catheter, but it is more than 15 minutes ago, so we should not worry. Anna, can you tell me what doses of acetylcholine do you use?
Yes. Good morning. We start with low dose with 2 micrograms after 20, 100 and 200.
Yeah. So it's basically the same protocol that we use in our hospital, at Hospital Clínico San Carlos. Now, the nurses have already prepared the doses.
Yes.
They have prepared this from a stock solution. And the idea is to inject it slowly over 30 seconds.
Okay.
But before that, we have already positioned in the mid LAD. We are going to show you where the wire is located. It's in the mid LAD. I'm going to make a small puff of. You can see where the wire is. It's actually positioned in a small branch, but we can leave it there. There's not much point in changing it now. And what we are going to do now is, through the same guiding catheter, making sure that we are delivering this. This injection that we made is very important, because we want to make sure that the acetylcholine goes into the coronary artery and not to the aorta.
Okay.
So perhaps we can just, can we replay the thing? But I think that let me check again. I think that, yeah, we are happy. So I think that the acetylcholine will be there. Now, Angel, we have here the pressure obtained from the Coroventis system. And perhaps we could go to the thermodilution system. So Angel is changing from the FFR modality in the Coronary system to the CFR-IMR modality. Now, this is a technique that allows us to perform hemodilution. The first thing we do is to make a zero in the temperature. You see that there is a button there that says zero temperature at the bottom, not on the top of start, okay? And we click on zero temperature. So we make sure that our temperature is zero. Yeah, we go there. It's a bit tricky with the mouse. Yeah. Okay, and we have zero temperature now. It's good. This is good because now when Anna is making the injection of acetylcholine, we will see the drop in temperature induced by this, and it may help you, Anna, in knowing that you are performing a slow and even injection. Okay, so Anna has the acetylcholine there, and now starts the injection. Can we have a clock? ¿Tenéis un reloj?
Yes.
Okay, we have a clock. Okay. So, good. Yeah. So no need to do anything there. Okay, and we start.
But we don't have.
And you start injecting, and you see that the temperature goes down. Yeah, that's very good. And you keep it something like that, stable. You see the white line indicating the drop in temperature induced by the acetylcholine. Anna is, eyeballing that it will be around 30 seconds. It can be 30 seconds. It can be 40 seconds. It doesn't matter. At this point, we tell the patient that if he has any symptoms, he should tell us. Si tiene alguna molestia, nos lo dice. ¿De acuerdo?
Dame suero.
Javier, Marcelo here. Can I?
Now, Marcelo will be in a second. Now, very important. Before injection, we make now a small saline injection to wash out this, and then we perform cine. And typically, what we do is we perform also an EKG. Cine. Good. So, Anna, what do you think?
I think by the moment, the angio is very similar.
Very similar, yeah, I agree. There are some changes induced by the contrast injection in the EKG. We don't pay much attention to that. The patient is not having any chest pain. There are some interferences, but I think that is one of the colleagues that is touching the patient. We should keep an eye. We should have, of course, a very good EKG. This is very important. Okay, so we go for the second dose. This is 20 micrograms, okay?
Okay, thank you.
So Anna is over to you. You can zero the temperature if you wish. I mean, just to remind, these important details, not for this thing, but time to time, if you see that there are deviations, you keep zero temperature. Okay, click. Good.
Javier, so, if you talk about the secondary effects of the acetylcholine, it's very important to the injection should be very slow because the rate of atrial fibrillation could be higher.
It's very safe. I can tell you there is an upcoming paper that will be showing that actually one of the factors that predict the development of atrial fibrillation is a history of paroxysmal atrial fibrillation. So think in these patients, also patients who have depressed left ventricular function, these are patients in whom it's more likely that you may develop a periprocedural or peritest atrial fibrillation.
Yeah,
okay, let's go for cine again. Okay, very good. For the time being, the patient is not having any symptoms. Okay, the catheter is in a stable position. I think we can go now for the 100 microgram dose. Now, atrial fibrillation is probably, the most frequent complication of the test. It happens in very few patients, approximately 2% of the patients that you perform the acetylcholine testing, and typically it resolves spontaneously, or it can be treated with amiodarone, of course. So this is, and as I say, in some cases, what happens is that this is related to a previous history or a predisposition to develop it. Try to avoid something that does not happen with this patient, big pauses. That's also that helps, So if you see that there is long pauses, you perhaps may decide to stop.
Okay. And you always start with performing the acetylcholine test before?
Not always.
Before not endothelium?
Not always. And, there are, at this point, there are some discrepancies. some colleagues prefer to start using the assessment of the
non-endothelial.
Okay, Javier, do you see any EKG changes? Because we are with the impression that there are some ST elevation. We were trying here to put some of the precordial leads, but
I think that what happened is that I don't know if we had some change in the leads. There was one of the nurses that was changing the leads. Vamos a empezar con este. But the patient is not having chest pain.
Okay, I think that's important.
And my impression is that actually there were some changes. What we do in our Cathlab is we use 12-lead EKG with radiotransparent leads. But I know that there was a problem today in the Cathlab, and the radiotransparent leads are not available.
People from the audience are asking what would be the ideal patient?
The 12-lead EKG, otherwise it's difficult to interpret. And then another point is when to do the acetylcholine. We usually do at the end. We first do the measurement of the physiology, and then we do acetylcholine. Why that? Because in case you have a prolonged spasm by acetylcholine and you have to nitroderivate, in that case, then this can invalidate the adenosine testing. That's why we do first the physiology and then we do the acetylcholine, and why in the document this was exactly how it was.
Although it's true that in the document, you know, we had co-authors that were doing it in one way or the other. Eventually, what we say is it doesn't matter much. And that's the reason. But if you, for example, if you look to Coromaica, in Coromaica, it was performed first the non-endothelium dependent pathway, so that means coronary flow reserve.
Yeah.
And the only caveat, or the only reason why you might not want to have acetylcholine testing to start with, is the theoretical idea that if you cause a lot of ischemia, because the patient has a very positive acetylcholine test, then you have subsequently blunted response. I think, have a look to the distal wire, because I think that probably is now, you know, that there was a bit of artifact due to the pressure sensor. So there could be, you know, a blunted response to hyperemia due to the ischemia caused by the acetylcholine testing. Obviously, it does not seem to be the case. But on the other hand, because we thought that this patient, the chances of being a vasomotor disorder very high, we decided to do this because first, if something happens, if for whatever reason you have to stop the test, you have already a very important information that is related to what you think that is important. Okay? Otherwise, you have ruined your study. And the second one, because, you know, I mean, we do it a lot of times. I mean, if the patient has, you have not given nitro or whatever, and now that we have given nitro for this last injection is when we can proceed to a coronary flow reserve.
Okay.
Yeah.
Good. So for the time being,
Angel
and the colleagues, Marcelo, I did not see much EKG changes.
Can you review the scene, Anna?
Yes.
The patient did not have any symptoms.
What do you think about the
And
flow?
what is interesting is that actually when we started the case, the patient had, I must tell you from the beginning, there was some
the basal angiography. This is the first?
Yeah, this is the first. This is when we just put the pressure guide wire in the patient. And we thought, oh my God, we are going to have a lot of spasm here. But, you know, this was resolved. And this, I can tell you that this was something like more than 20 minutes ago.
This is after the...
And Angel, a question for you. Do you already have administered the 200 micrograms of acetylcholine?
Yeah. So we gave the full dosage.
Second question, do you think the nitro given 15 minutes ago for this focal spasm induced by the catheter could influence or give a false negative result of the acetylcholine test?
Yeah, I mean, this is life. It's one of the difficult things. What the answer from an academic standpoint is no, because theoretically the effect that it has is very short. So certainly in 5 minutes should be gone. So, you know, you always have pro and co in this interpretation of things. And my impression is that, with this patient have been receiving after 200 micrograms as acetylcholine in the coronary arteries, 20 minutes later after giving nitro, I will personally interpret this as a positive thing. Otherwise, thinking in Coromaica. In Coromaica, the colleagues started by performing coronary flow reserve and giving nitroglycerin. Yeah. And after that, they performed the acetylcholine test. So the argument that, what it was, Alaide was suggesting, we always start, with the coronary flow reserve. In that case, you will be in the same situation like us. I mean, this patient will have received nitroglycerin something like 15 minutes ago. So,
there is
Anna,
a nice question coming from the chat. If it makes sense to perform the test in both left and right coronary arteries. So what do you do normally? You do in both arteries or you do just in the left system? I think it's a good point.
So if you think that the vasomotor problem is in a particular vessel, then you should perhaps consider performing it in that vessel. That is the case in this patient. I mean, this patient presented with all the evidence, including the MRI data, is suggesting that the LAD should be, the vessel we interrogate. But if you have someone who has definite information suggesting inferior wall ischemia during the test, then of course you should consider. And typically you use half of the dose of acetylcholine that you use in the left coronary artery. Otherwise, for all other patients, we just study the LAD. And of course, at the same time, we have an eye in the circumflex, etc.
I would like to remind that I know this patient, and he was admitted because of suspect acute ST elevation MI from the 112 emergency department here in Madrid. He came to the Cathlab as a primary PCI, and he had normal epicardial coronary arteries. Later on, he had troponin elevation, and we performed an MRI, which you saw the images was diagnostic of subendocardial myocardial infarction of the distal LAD. And he then came back to the ER with another rest angina episode and had a very tiny, small troponin elevation, and he was treated with calcium channel blockers during the past 2 weeks, and he's doing well. So our first suspect was a myocardial epicardial spasm.
Javier, one question is about. I am concerned about the diagnosis of endothelial dysfunction and vasospastic angina. With these doses and bolus of acetylcholine, can you assess endothelial dysfunction or only the vasomotor effect in the coronary artery?
It's a very good question, and this is something that many people sometimes do not know. The doses of 2 and 20 micrograms stimulate endothelial function or allow assessment of endothelial function. Once that you reach 100 or 200, you are also stimulating a smooth muscle cell function. Now, remember that there is big debate about that, but typically what we believe is that endothelial dysfunction plays a much more important role in ischemia caused at the level of the arterioles, while vasospastic angina in epicardial vessels is more a problem of smooth muscle cell hyperreactivity. So the beauty about the acetylcholine testing is that you interrogate both endothelial dysfunction, that you can look with QCA the changes in the caliber of the vessel, etc. But also you can check for epicardial spasm. If you use ergonomine, for example, you're just exploring one of them. Okay. So I think we could know, Anna. Okay. So we move to look to what happens in the endothelium-independent part. So again, Angel, let's zero the temperature. Has been shifting a bit, and I want it to be 0. Good. And now comes, the very interesting part. What we are going to do now is to obtain a number of measurements at baseline and during hyperemia. And with that, we will be able to calculate coronary flow reserve and macrocirculatory resistance. Now, the key aspect in performing coronary flow reserve is getting very good resting measurements, And again, there's a lot of confusion about this. So what we're going to do is simply taking 10 cc syringe, this is the way I do it, and then perform brisk injections of about 3 cc's each time. You will see how the pressure goes down. I'm not going to start yet. I'm just going to inject some saline and look how the temperature goes down in the same way that it happens before when Anna was injecting the acetylcholine testing. Now, what I'm going to do first, before Angel presses start, I'm going to make sure that the temperature inside my catheter is the same that we have in the saline, okay? So give me another syringe, okay? So I flash the warmed saline inside the catheter, and now can you press start, Angel? Press start. Now is when I make my first injection. Brisk injection. You can see, I don't know if you see my hands, but it's brisk injections. Wait, another one. Can you give me a piece? Okay, just making sure. Okay, and you can see that we are having some resting times of 118, 117, and 0.93. Can you click on the 0.93, please? I'm going to replace this one because I think that this is, I'm aiming for longer times here. 2.0. Go to 117. Pressing 117, please, quickly. Yeah.
We have a questions regarding this. How do you select your time?
Go to 118, please. Yeah. Okay, so I prefer to invest a bit of time in making long. Okay, and go to the 0.0, 2.0, click 2.0, quickly. Okay, thank you. Okay, so I'm very happy with that, I have 139, 150, 146. There are long times. I can give you, this morning I was doing a study at Hospital Clínico San Carlos, just to give you an idea, the mean transit time was about 0.50. So this patient has much longer transit times. That means lower resting flow. So this is good news, okay?
Yeah. I have a question from the chat, from the audience, and it's regarding how do you consider, which variability would you consider excessive in these times? How do you discard?
I think that you get used to it, but what is very important is the procedure that we were trying to do. We are trying to look, for longer times as possible at the resting point. This is the key aspect. And then, I will basically accept this type of a small variability. It's very small. Now, what we're going to do now is to start injecting the adenosine. And we start now, and we need a clock, Anna.
No, in the meantime, we have a question from Dr. Alaide. While adenosine, we have 2 minutes. Dr. Jesus Garcia from our hospital asks if her opinion or the panel about neuromodulation techniques such as spinal cord stimulation for treating sometimes difficult patients with microvascular angina or refractory angina.
Yeah, I mean, we use these for refractory angina in patients who have coronary artery disease but cannot be revascularized because, I mean, there are no targets for revascularization. So we use that in those kind of patients with good results. However, we don't use these for this kind of patient. So for us, the experience that we have is only for diffuse coronary artery disease that have no target for revascularization. Indeed, personally, we do not have experience for patients with microvascular angina or vasospastic angina treated with this kind of therapy.
Okay, Javier, go ahead with.
Sorry, 30 seconds now from adenosine because there were some problems with the pump that have been fixed. And typically, we recommend to wait for at least 1 minute and a half or 2 minutes. In the meantime, of course, you can keep an eye on what happens in aortic pressure. As you know, in many patients, what you have typically with intravenous adenosis is a drop in aortic pressure. We know that patients who have big changes big drops in aortic pressure in response to intravenous adenosine also have decrease in the microcirculatory resistance, something that is very interesting. So probably that's something that we are seeing out there. So it's 124. Very important, of course, checking that the patient has not had caffeine over the last at least 12 hours. Okay, it's very important.
To avoid this, I'm sorry, Javier, to avoid this, would you move in the future to a saline infusion with a microcatheter, the Exacat micro?
I think that once that a number of things, we can speak about that later. Thank you. It's a very good point, Marcelo. But it's a very interesting point. Good. So what I'm going to do now, I'm going to flash slowly, and then you click in the first square for hyperemia. Okay. Again, I'm flashing. Okay, and then you can click. Yeah. Thank you. Now, of course, what will happen is that typically you don't have beautiful. You can see, dame más, por favor. Sí. So 0.23, 0.18. Go for the shorter. Yeah, go 0.23. Click on 0.23. Okay, thank you. I'm concerned that there was a small yeah, you know what happens now with this 0.29? You notice that the adenosine was blinking?
Yeah.
So I think it's running again. We are going to wait for a second because it was a dip in adenosine diffusion for a while. No? Mm-hmm. Okay. So click in wait for a second. Wait for a second. Okay, and in 0.29.
Yeah.
This will, yeah. Click there. Thank you. Okay, interesting. Click in 0.30. 0.30 is the one that is faulty. No.
Yeah, it's very difficult.
Yeah, I know. Okay, good. Okay. Yeah. And then we can say end. You can see there's a small thing saying end there. Good. And then we can say click end and save. Good. And we can stop the adenosine infusion. So, wow, coronary flow reserve 7.4, young patient. Microcirculatory resistance 17. Okay. So first thing that we see there, Anna, is a very clear separation of the curves obtained at rest, which of course are the blue ones, means that with the resting flow, it took long time to recover the temperature. Actually, it took 1.45 seconds to recover the temperature, okay? While during adenosine, you can see clearly that it took only 0.19 seconds to recover. So it's a great coronary flow reserve. Only with thermodilution, you can get these huge coronary flow reserves, which actually perhaps, even from a realistic standpoint, perhaps is a bit exaggerated. But anyway, it clearly speaks of a normal vasodynamicity of the arterioles in regulating blood flow. And at the end of the day, the most important aspect to assess in the coronary, in the microcirculation, is to know if the dynamicity of the arterioles is preserved or not. We want to make sure that they are able, to deliver more blood when there is increased oxygen consumption.
Yes.
And the conductance of the microcirculation is very low, 17 units. Okay, so it's very, very low.
Yes, I have one question. Why it isn't lower the PDPA after the adenosine is completely the same? Do you think that we may have lost the equalization? Or?
Well, we will see that. That's a very good point. So why don't we go now to live again? Go to live. Okay.
My question for the panel is, we have a young patient with presumably ST elevation MI who had an MI. This is a INOCA case. He had an angiogram at 30 minutes after chest pain, so we could have excluded any embolism. We saw troponin tests compatible with infarction and magnetic resonance compatible with infarction, but we don't see the reactivity from the epicardial nor microvascular disease. So he obviously is not non-cardiac pain as the expert consensus. What is the diagnosis here?
Well, the first thing is that MINOCA is a very complex, much more complex diagnosis at this particular point than INOCA. So you have multiple causes that may explain that this patient had a myocardial infarction, that are not covered. We are just looking to one specific aspect, but there are many more things that that we have to take into account, and that's the reason because if you embark into MINOCA, remember that in most cases what you are doing is excluding this, excluding that, excluding, and then you in 80% of the cases you will find a cause, a tentative diagnosis, but sometimes you will not find the mechanistic process through which the myocardial infarction, who this young gentleman certainly had. So,
do you think in this specific case there must
vamos a empezar una grabación.
Also imaging?
Empieza a grabar.
Because in case of MINOCA, I mean, imaging I think can be also important. For example, if the patient has a SCAD that is not possible to diagnose by angio, I don't know. I mean, thinking about other causes of MINOCA. So if the patient had ST elevation and has a positive troponin, to understand, because the function, I mean, all this testing was negative. Acetylcholine is negative, the physiology is negative. So maybe imaging on top of all this evaluation, considering this is a MINOCA case, an OCT.
Yes, it is a comment made in the chat also. It is important in these cases to perform OCT to check if any plaque erosion at the time of...
And then Javier...
You probably noticed that we have performed the final check, which is making sure that the calibration persists. We have, a PDPA of 1.01, so typically we should admit that this is good. And of course, we always perform, a new injection. Guiding catheter went out, but we always perform a final injection just to make sure that we have a good image.
And then about the treatment, Javier and Alaide, which treatment
I think that we have to close the circle. So I think that imaging, or if you want to do imaging, a CT scan, I mean, we have to understand morphologically if there is an issue, if there is a recanalized artery, I don't know, if it was a vulnerable plaque that maybe caused myocardial infarction that for whatever reason recanalized, if there was a scab or whatever it was. I think that we have to complete diagnostic. So we did only now the evaluation if there is vasospasm or if there is abnormal coronary physiology, but we don't know about morphology rather than geography that is limited in my opinion.
Okay, then now it's 3 p.m. I think it's time to finish. Javier is trying to show us the last injection.
Yeah, just to make sure that everything is,
it's okay.
Good.
And Javier, tell us the closing remark about this case and about your experience with assessment of the microcirculatory system.
Yeah, we will make it in a second. So I think that Angel, I think that this is a very interesting case. Again, MINOCA cases are complex. The objective of this was to demonstrate that there will be an abnormal vasomotor disorder, accounting for this. Honestly, after seeing that, waiting and after we gave the puff of nitroglycerin, not having response up to 200 micrograms of acetylcholine, I think that we can be safely said that this patient does not have a vasomotor disorder that can be triggered. And we also have very good news in terms of the integrity of the microcirculation from a structural standpoint in the left ventricle descending, and a preserved dynamicity of the coronary microcirculation that could be clearly demonstrated. So I think it's all good news for the patient. And in terms of understanding what happened, is something that perhaps needs to elaborate more and to revisit the notes, etc. I mean, as has been mentioned before, INOCA can be caused by, in some occasions, by episodes of myocarditis, can be caused by, obviously, SCAD is not the case, but can be caused by a number of embolizations or something circumstantial that has disappeared. Okay, I'm not referring to this gentleman, but for example, it's something that we may think in people who have an intake of cocaine, for example, at a certain particular point that may cause extensive discussion and disruption of the regulation of the coronary circulation.
Okay, it's time to finish. Thank you so much. Thank you, Elaide. Thank you, Javier. Thank you, everyone. And see you in 2 weeks. Thank you, everyone. Bye.
Thank you. Thank you much.